you. Let us just make sure that the slides are working. Okay, so David will go over the non-allergist, the skin test. Who is not allergist here? All of you are allergists, actually? Then, yeah, then you didn't need to tell me here. All right, okay. David.
Thank you, Bassam. And many thanks for the invitation to speak today. It's a great honor, and welcome everybody. So I'm a consultant pediatrician at Mediclinic Parkview, but I see children with allergy. And I'm just going to talk about allergy tests. All patients want an allergy test. So perhaps if you're not an allergist, let me give you some advice, maybe how to interpret those and when to do them. So when it comes to asthma, allergy is definitely something to think about, and we may be able to improve asthma care if we know about whether they are allergic to something. But asthma is a serious condition. People die, people have many attacks. And of course, the crux of asthma care is the basics of asthma care, which I'm sure has been discussed so far this conference. But I would like to mention a document that's been around a few years now. And certainly if asthma care in your clinic, in your hospital is something you're passionate about, there's many good learning points here. Look, because they looked at why people, adults and children, were dying from asthma in the UK. It's 8 years old now. Sadly, very little has changed since that was published, but it's got great insight and lots of learning points in that. Now, when it comes to allergy, there's this phenomenon called the atopic march, whereby we see different allergic conditions depending on the age of the child and the adult. And allergy normally starts early in life, and those conditions that present in babies and young children are going to be your eczema and food allergy. And as that child grows, the eczema and food allergy does improve. We see children outgrow their food allergy, particularly dairy and egg, and their eczema gets better. But then as the child grows, other things come in, hay fever and asthma, and these are more persistent going into adulthood. And the key thing, certainly when I see a child with allergy, is often they have more than one problem. And there's close linking between these different conditions. So for example, atopic dermatitis and food allergy, very closely related, and atopic dermatitis increases your likelihood of developing a food allergy odds ratio of 6, so very high. Atopic dermatitis and asthma. Certainly atopic dermatitis increases your likelihood of developing asthma, and also the severity of atopic dermatitis is linked to a more severe form of asthma. And that now atopic dermatitis is the genetic condition in the main around filaggrin mutations, and potentially filaggrin mutations in the lining of the airway may increase your risk of sensitization like it does in the skin. And then food allergy and asthma. So like Dr. Ravi I'm going to talk about food allergy testing, and this is just a slide really just to show that in eczema, allergy testing is not helpful. When it comes to eczema, let's look at what's going on from an immunologic point of view. Very complicated. And actually, IgE, sorry, it's blocked slide. There's, as we can see here, and of course, not all of these are going to be allergy, but there are some: pets, food, possibly pollens, and dust mite. And again, the key thing regarding diagnosing allergy and interpreting any tests in asthma is taking a good history. Does your patient have allergic rhinitis? Allergic rhinitis is itchy nose, runny nose, blocked nose, sneezing, and what's coming out of the nose is clear. And absolutely, there's a very close association between asthma and allergic rhinitis. We believe up to 80% of patients with asthma have allergic rhinitis. But ask about these symptoms. When it comes to what they may be allergic to, is there some seasonality to their asthma or allergic rhinitis? Are things worse at certain times of the year, such as summertime, springtime, when they go back to their home country, pollens, etc.? Ask about pets at home. And then if they do have a pet at home, is there any obvious history to suggest this pet may be a problem? Do their symptoms get worse when they go home? Do their symptoms improve when they go on holiday? In a dusty place or after vacuuming. Of course, I see a lot of coughing. Absolutely not. They wouldn't survive that. That's just irritation from the dust. Children I see, because I see children, that parents worry about allergy because they have a runny nose, but often it may just be a virus. And what clues may there be in distinguishing a patient from a virus? Not sure whether there's allergy or not, then absolutely do some tests, particularly if their asthma is poorly controlled, just to make sure. And what's the best test? So I do some, obviously allergy doctors do skin prick tests. They are useful. We can do them in the clinic, but we can't do them if the patient's on antihistamines. But it's not an option for most doctors. But most doctors can do IgE tests, a blood test. There's not influenced by treatment. They can be done at any age. I think some people think you can't do them at 1 year or 2 year. They can be done at any age, but obviously we're only doing that if we think there is IgE allergy. We wouldn't be doing it in a baby if there's no record of any problem. But if a baby has had an IgE reaction to food, even at 3 months, then we can do an IgE test on that baby. And I think if the history is not clear, but we have somebody with symptoms and suffering, but we're not clear what the problem for dust mite allergy. We can consider nasal steroids. There are home measures that they can do, particularly bedding covers for the pillow and the mattress that has some effect. Look at reducing humidity. And there may be an option to consider immunotherapy for dust mite allergy if their asthma is well controlled. Pet allergy, we have the answer. Keep the pets outside the bedroom, remove carpets. Of course, there's no such thing as a hyperallergenic pet, apart from the toy pet on the right there. That's the only hypoallergenic dog around. What you are allergic to from a pet is protein in the urine and the saliva, which all dogs have. Dogs that shed hair, maybe that protein hangs around in the house more, may cause more symptoms, but they are still shedding that protein that you can be allergic to. And then if you find someone with pollen allergy, you can target the treatment for only the summertime if they are fine during the winter, and start the steroid. Always ask them, how was that diagnosis reached? What happened? What happened when you ate the food? And this doesn't always happen. Because when it comes to testing, what happens is that often patients, if they come to a story of food allergy, the doctors will do a food panel. So this patient was a girl I saw in clinic. IgG is a marker of tolerance. It means that you are less likely to be allergic, not more allergic. And of course, having IgG to a food is a normal phenomenon. That's the pathway we want people to go down when they eat the food. So absolutely, it's a highly inaccurate test and shouldn't be done. Yes, they are useful, but do rely on your history. Looking for some other triggers that we can indication for those. Asthma care, your basics is your priority, but do look at the nose, do treat it. Thank you very much.
For allergic rhinitis.